This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
From the doctor perspective, we're often seeing the person with exacerbations and infections and that. But from the patient perspective, apart from the infections, the biggest impact on their life is often breathlessness. And pulmonary rehabilitation has a really big impact on that. So it's something we should consider. And is, like spirometry, available at the hubs in a large areas of the country. Probably 70 to 80% of the country now we can access this.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined by Dr. Shane McKeough, lead author of the new Irish College of GPs COPD GP Update, which was published in October 2025. Here's Shane.
Shane McKeough is my name, and I am a GP in Rathfarnham in Dublin, and I'm the adult respiratory lead for the Irish College of GPs. I also work as one of the chronic disease leads with the HSE and advise there as well on behalf of general practice.
Today's episode is part 1 of 2, covering the new GPU and continues our April focus on chronic disease management topics, which began with Dr. Lisa Devine's 2-part series covering the new type 2 diabetes GP update, and those episodes are available in the show feed now, along with Dr. Eamon O'Shea's overview of the new atrial fibrillation GP update back in episode 2, and that GPU was published in October 2025. And to round off April's CDM focus, next week Dr. Eamon O'Shea and Dr. David McConaughey will discuss efficient and effective implementation of the HSE's opportunistic case finding, prevention and chronic disease management programmes in practices of all sizes. In today's discussion with Shane, our source text, the new college COPD GP update, is now available and free to access and download if you're a college member, and I've included a link to the download page in the show notes. And of course, I'd encourage listeners to go ahead and download the GPU itself for the full text and additional resources. And as usual, the GPU is written with the busy clinician in mind, featuring links on the front page to areas that GPs are most likely to need quick access to during a busy clinic. Shane and I refer to relevant page numbers of the GPU as we go along through each section in today's conversation. So if you have the GPU to hand while you listen, you should be able to follow along. And as usual, I've included chapter markers and links to numerous resources signposted today by Shane. Areas covered in today's episode, which again is part 1, include how COPD management has been streamlined and simplified in recent years, the role and value of new HSE community hubs in more timely diagnosis and patient support, assessing newly diagnosed patients by considering breathlessness and exacerbations, and non-pharmacological management strategies for COPD. Then part 2 will pick up the conversation with topics including pharmacological interventions based on breathlessness and exacerbation assessment, an approach to augmenting therapy for symptomatic patients with established COPD, the role of eosinophils, and the evolution of care in Ireland via HSE integrated care hubs and the CDM programme. I hope you'll find my conversation with Shane useful in the management of your patients with COPD, whether suspected, newly diagnosed or well established. And before we get on with today's show, I would just like to take a quick moment to thank all of you who've contacted us at podcast@icgp.ie, as well as those who've taken the time to rate and review the show on Apple Podcasts and Spotify. As I record this, we've over 65-star reviews and we're really happy with the reception to date. And if you're enjoying the show, please consider recommending us to a colleague or even leaving us a review on Apple Podcasts or Spotify to help us continue to grow. Okay, let's get on with today's show. Shane, thanks again for joining me today. Could you begin, please, by telling listeners how guidance on COPD management has changed in recent years?
what I would say is the guidance for COPD has been significantly simplified in recent years, which is music probably to most of our ears, because it was always quite a tricky thing to manage. And the exacerbation piece was not too tricky, but in terms of dealing with perhaps new diagnoses, it was quite complex in terms of how to approach it. I would say now it's relatively straightforward. So hopefully listening to this podcast today will help with that. But also this general practice update around this has all the key pieces you need. If you're thinking back after and you're seeing a patient in a week or a month or a year and you're thinking, what did that fella say on the podcast that day? Have a look at the GP and it should be very quick to answer the question for you.
And we're going to get straight into the general practice update now. And as usual, this is available in the show notes and you can click on the link that you'll find there if you want to follow along, and you might get some extra value from that. There are 4 quick links, Shane, on the front page of the general practice update. And again, like the other ones, it makes it so easy in general practice if you have a patient in front of you to get to the information fast. The 4 links we're going to cover are assessing a newly diagnosed patient, approach to the pharmacological treatment, the algorithm for following up pharmacological treatments, and management of acute exacerbations. But before we get there, why don't we start at the start, and maybe you could give me an overview of how to actually make the diagnosis.
Yeah, great. So I suppose to make a diagnosis of COPD, this is in a patient that you don't know has COPD, but maybe you're suspicious that they may have it. So this is not an uncommon presentation to a GP. And the obvious things here are what might make you suspicious of this. So perhaps you have somebody who's coming in with shortness of breath over time. That's often something that becomes a little bit progressive over time. So they've mentioned it to you. They might be somebody who is coming in with a chronic cough. Or they may have you might have somebody who is coming in with recurrent chest infections. These are the kind of things where you might think, could this person have COPD? Now, the way in which GPs should then approach that is, if you think this could be COPD, obviously there's other things that can cause those symptoms as well. So you want to examine the patient and perhaps do a chest X-ray to make sure there's nothing else going on. But a critical piece around this is to do spirometry. Now, we've all heard of spirometry, and until relatively recently, that was largely a hospital-based test. So if we were thinking, oh, jeepers, this person might need spirometry, you would often refer to the respiratory outpatients and they would take it on from there. But there's been a big change in Ireland over the last sort of 5 years or so, whereby the advent of the community hubs have been launched around the country. And specifically, spirometry is designed there for direct GP access. And COPD, really, it's mandatory to have spirometry to make a diagnosis of COPD, is what I would say. So you can suspect it, but ideally you would want spirometry to clarify that. And it has been, with the advent of the hubs, it's available now in a large areas of the country. So right from the western seaboard across the Midlands and the eastern seaboard, all have access to spirometry if you have patients living in those areas. I should say on that point, in terms of accessing spirometry, it's based on the patient's address rather than where the GP surgery is. So if you're trying to figure out which hub to refer a patient to, use hscareafinder.ie, which is a great tool, and you can Google that at any point and put in any address in the country, and it'll tell you what the local services are that patient's address is linked to, and specifically the hub as well. And then on HealthLink, if you have a look at that hub, you'll be able to see in the drop down, if you choose hub respiratory, is spirometry available there. And what I would say is it's available to probably 70% of the country at the moment, so a lot more than people realise. And it's a very usually accessible test for GPs to access. So you would refer a patient for spirometry using HealthLink. So you choose public, the CHO area, respiratory, and then spirometry. Patient goes, often not that long of a wait, could be 6 or 8 weeks, and you'll get a report back. And the report will should be giving you a clear-cut piece as to whether this is consistent with COPD. There is specific, what we call FEV1 and FVC ratios here, and it's less than 70%. But I don't want to get too technical about this. It should be coming back on the report to you if that's consistent with COPD. So if you're sending your patient going, this is somebody I suspect is COPD, could that be accurate? It should come back that way for you. If it does come back with the numbers and you're thinking, I can't interpret that, I can't remember it anymore, have a quick look at the GPU and that will give you your answer. And really, if you have a patient who you think is COPD and the spirometry numbers go with that, your patient has COPD. That's it. Your diagnosis is made. They don't need to see respiratory. The only reason you would need to refer to respiratory in this context is if you're in an area that doesn't yet have spirometry. And what I'd say about that is the HSE are working hard to iteratively build spirometry in all areas, in all hubs. There's been some delays because it's a new service getting in personnel or equipment, but it is iteratively building, and it is worth keeping an eye on that. In terms of the HealthLink drop-down, they are updating that on a monthly basis. So although you may not have spirometry last month, it's worth looking again in a couple of months and seeing if it's come on stream, because that's where you will see it first. So worth knowing from a GP perspective. Keep an eye on the HealthLink drop-downs.
Okay, that's really clear cut. Thank you for that, Shane. And, you emphasise the importance of spirometry before confirming the diagnosis. And I suppose one of the real game changers in the new model of care whereby the respiratory hubs are being rolled out is that you're minimising that delay from diagnosis to treatment.
Yeah, I think it's an important point. I think the hubs this hasn't happened by fluke. It was planned that the chronic disease management program would be supported by GPs having direct access to diagnostics, and those hubs were built specifically for GP access. So one of the things they want us to be able to do is be able to access spirometry, so we're not blocked from making these diagnoses and we can get to help the patients quicker. And certainly if you talk to GPs who have this in their area, it will be a game changer in that area, and you will be able to really get the test quite quickly for many people. Just the other point I would say there is that the evolution of the hubs alongside the chronic disease management program are probably one of the first tangible manifestations of Sláinte care in action in the community, and are directly relevant to general practice because they're designed to support us helping patients much more directly, much more efficiently, where in the past we wouldn't have had an option but to send a patient into a respiratory outpatient waiting list. In a large number of these cases now, we can manage them directly because we can get access to the tests we need, and we understand how to take it forward and help the patients.
And I don't think GPs need to be told that, along with so many of the other chronic disease management conditions, as access to earlier diagnostics allows us to make earlier interventions, outcomes improve, and even from an exchequer perspective, the burden on the taxpayer, if you want, for want of a better phrase, is lessened by earlier intervention and different trajectories of illness for our patient cohorts.
That's completely correct. Historically, a lot of people would have been diagnosed with COPD after hospital admissions when they've been quite ill. So what we're trying to do is identify issues at an earlier point, pick them up at an earlier point, intervene, which will help the patient feel a lot better of themselves, and then obviously hopefully have less problems where they may be getting less exacerbations, less emergency departments, less emergency department visits, less admissions. So it helps everybody, and at 100% that's the principle. This is highly relevant, of course, as we have a growing population with people getting older, living longer, which is great, but obviously we now live longer with more conditions. So we want to pick this up and intervene and help. And general practitioners, my colleagues listening, don't need to be reminded of this, but we are the front line of healthcare. We're right close to the patients and we can see the problems. So arming us with the tools we need to do our job more efficiently is only a very positive thing and good for everyone.
When I hear that message, Shane, I immediately think chronic disease management and the benefits of that, which of course we're going to interweave in our management of our COPD patient over the course of this conversation. But I might park that for now. My patient has just come back from spirometry. I was suspicious. My spirometry report confirms my diagnosis of COPD. What now?
Okay, so you've now got your diagnosis of COPD. So now you want to assess the patient, because if in your head you're thinking, right, what do I need to do here? How am I going to proceed with the patient? Do they need inhalers? If so, what inhaler? So the international guidelines around this, which have been summarised neatly into the General Practice Update for Ireland, really simplify this from a general practice perspective. There are two things that a GP wants to assess, and they're both history issues, right, for somebody with COPD. So you've got the spirometry has diagnosed COPD. We want to ask two questions. Number one, how breathless are you? Effectively. And number two, how many exacerbations have you been having? So these are we're often in general practice training, we talk about open questions. These are the opposite of this. We want to use closed questions. Okay. So we're not actually saying, well, how breathless are you? We want to use a validated score on that. And that's called the Modified Medical Research Council score, or MMRC. The naming doesn't particularly matter, apart from to say it's a validated score for assessing the level of breathlessness somebody is having. And listeners might recognize that because this is built into the CDM data set. So you might see MMRC. And that's a scoring system based on how breathless are you on a 0 to 4 scale. 0 is not breathless at all. 4 is so breathless you can't leave the house. And there are different levels of that where you can say to a patient, well, how breathless are you, and ask them these questions, and the MRC will give you a score of 0 to 4.
And just to interrupt you for a moment, I should say this is on page 3 of the General Practice Update, and we're now into our first link. So this is not something that listeners should feel like they have to memorize, because I suppose, reflecting on my own practice, it's one of the challenges I would have faced with COPD management, is trying to keep it all in my head, and also trying to find a resource that was succinct enough for use with the patient in front of me. And I guess that from my perspective, the GP update fulfills those criteria. So you open it up, you click on the first link there, and it's how to assess a patient with newly diagnosed COPD. And here we are. And what you're describing there in terms of the MMRC is right in front of you on page 3.
So that's exactly right. So obviously we're talking here with a podcast today, and I'm having to reference certain links or certain images that are worth looking back to. But I completely agree. Have a look at the GPU at the time, because it will give you this in a really easy piece. Really what I'm looking to get across here are concepts. I don't want you to be remembering the exact ins and outs of things over a podcast, but the concepts to say, ask about breathlessness using that score. And the other piece is ask about exacerbations. So exacerbations are also broken up into what we call mild, moderate, or severe. And quite simply, mild are exacerbations a patient may have. They never go near a doctor. Okay. Moderate exacerbations are ones where they have to come and see us as GPs, or go to a GP out of hours setting. Or severe is the patient has had to go to hospital, either the ED or being admitted. That's all that they are. So you're interested to know, you've got your patient who has COPD now, because you know that from spirometry, and you're saying, how breathless are you on the 0 to 4 scale? And how many exacerbations have you had in the last year? And based on the answers to those two questions, you will be able to place the patient into a box of what is called Group A, Group B, or Group E. And again, there's a little algorithm here on one of the pages in the GPU. Essentially, Group E stands for somebody who's having a lot of exacerbations. So if you're having even more than one exacerbation in the previous 12 months, that patient is by definition a Group E patient at diagnosis.
In my head, at least, this is such a simpler approach. Just by removing the A, B, C, D older goal classification, I, for one, found it, again, challenging to memorize all that and keep it in my head. But this A, B, and then the E exacerbation category just simplifies it so much for me. It's much more approachable, I think, when you're in day-to-day practice. Yeah,
I think that's a really good point. And something I should have said here is that spirometry, really from a GP perspective, is useful only to make the diagnosis. It doesn't have a role in really defining which group the patient fits into. The group they're going to fit into, you put the spirometry aside once you've got the diagnosis. Now you're just interested in how breathless are they on the 0 to 4 scale, and how many exacerbations are they having. Those two questions define Group A, B, or E. So E equals exacerbations, so this person is exacerbating. Group A or B really is for people who haven't been having exacerbations, but rather less or more breathless, depending. And it's as simple as that. Depending on the answers to those two questions, you are placing the patient at diagnosis into one of those three boxes, and that has a direct correlation with advised treatment on the back of that.
Thanks, Shane. Now we've made our diagnosis. We've done that initial assessment. We've assessed symptomatology, and now we're going to think about treatment steps. So what do we do now?
Okay, well, broadly in terms of what we're going to do here, we break it into what we call non-pharmacological management and then pharmacological management. So GPs listening to this will immediately think of inhalers, and they are obviously very important to COPD. But I would just want to talk a little bit about the non-pharmacological management piece, because that's also really important, and there's been significant changes in this in terms of what we can do as GPs in Ireland in this area. So just on the non-pharmacological piece, this covers every patient newly diagnosed with COPD, irrelevant of whether they're group A, B or E, okay? Education for somebody obviously is very important, and we would automatically do this, and we're very good at this traditionally as GPs in terms of educating patients, letting them understand what's going on, perhaps give them a resource to read. What I would say on that is there's quite a good resource here, COPD and Me, available from the HSE, which can be a good piece to give out. You could also consider if it's available in your area, referring to the respiratory nurses at the hub for education. Again, that's through the HealthLink drop-downs. If it's available in your area, which it is in many, that could be a useful resource in the education piece. Smoking cessation is always relevant, and lots of times we think automatically smoking in COPD. It's just useful just to stand back for a second and note that 20% of patients with COPD have never smoked. So it's not all about smoking. A significant minority of people with COPD, we know that it's actually a genetic predisposition with various environmental factors then affecting it, which triggers the COPD. So although smoking is a very important point, it's not the be all and end all. However, if you do have a smoker, somebody who is smoking, it's worth a brief intervention on that. And we know that that's highly effective. Even just signposting to a patient, do they want to think about it and come back to you on another occasion? You'll be surprised the number of times people will do that. Okay, so it's always worth a brief intervention on that piece. Vaccinations are always relevant here. The COVID, flu and pneumonia vaccinations in particular. COVID and flu being annual. Pneumonia is typically 5 yearly or once if somebody's over the age of 65. But I suppose the big non-pharmacological piece here is what's called pulmonary rehabilitation. And that was a totally new concept to me when I started in this role a number of years ago, and I suspect to many of my colleagues around the country as well. So pulmonary rehabilitation is a 6 to 8 week course that patients can access. And it is highly effective for the treatment of breathlessness in COPD. In fact, it's probably the most effective intervention we can make for people who have breathlessness in COPD. So if you talk to patients who have COPD, from the doctor perspective, we're often seeing the person with exacerbations and infections and that. But from the patient perspective, apart from the infections, the biggest impact on their life is often breathlessness. And pulmonary rehabilitation has a really big impact on that. So it's something we should consider. And is, like spirometry, available at the hubs in a large areas of the country, probably 70 to 80% of the country now we can access this. It is, as I said, a 6 to 8 week course where patients go to what are typically physiotherapy and nurse-led services, where it's a combination of education on their condition, cardiovascular work and strength training. And it is very effective. What tends to happen with COPD, apart from the disease process itself, which causes shortness of breath in many patients, people then become deconditioned also because they are not actively exercising, which actually further will make people feel more short of breath. So you have two processes at work, the COPD itself, but also the deconditioning. And this is where pulmonary rehabilitation is so effective. So I would encourage GPs to think about it and to consider referring for it. It's particularly useful for people who would have an MMRC score of 2 or greater when we're assessing breathlessness.
And on that point, just to bring the MMRC score of 2, that just means I'm slower than people of my age for doing a given activity. For example, walking. And I was really struck by that. The threshold for actually qualifying for pulmonary rehabilitation is quite low. And the way I'm kind of remember it is to say, I'm going to help you catch up with your friends, which is, and also it goes back to that idea that you have of this negative cascade of, I can't do it, so I'm going to isolate myself potentially from my friends and from my usual routines, which makes my symptoms worse, which makes my activities even less. And we've all seen that day to day. So this idea of, well, here's a gateway to catch you up is a nice one for our patients and a message of hope, I suppose, for the future.
It is, and I completely agree with that. And it is, as I said, highly effective. And the feedback from patients around pulmonary rehabilitation is excellent. it's also just worth noting again that these services are available through the hubs and are ring-fenced for direct access from general practice, a significant portion of their time. And lots of times they are really looking for us to refer. So I recognize which is not a common message we hear. You know, these services are now built and are waiting on referrals. So it's things that we really need to consider as a GP. And I appreciate they're new to us, but that's what this talk is about today, to try and signpost us in that way.
Yeah, really fantastic and important message there, Shane. There's other resources there as well in terms of non-pharmacological management, including COPD Support Ireland and nutritional support. And there's links in the GPU, which I'll also include in the show notes. Many thanks to Dr. Shane McKeough for speaking to me today. And don't forget to check the show notes for chapter markers and links to useful resources. As a reminder, part 2 of this conversation is also available now, so please have a listen. You'll find it in the podcast show feed. Thanks again for all your support to date, and please feel free to get in touch by contacting us at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.